Hey, good morning, everybody. I have 8:03. Maybe this is a good time to get started. And I thought perhaps it would be worthwhile if we quickly went around the group and introduced ourselves. Um, I'm Evan Klass. I'm in my home office and joining remotely at Project Echo Nevada, our hub team.
I'm Veronica Brady. Who am I?
Who are you today, right?
He said, sorry, I'm Veronica Brady. I work in endocrinology at the university. Nurse practitioner CDE, thank you.
Carmela Thomas, dietitian and CDE.
Troy Jorgensen, program coordinator here for Project Echo. So we'll go around the group here and see who you have joining us today too. So Danny, do you want to start us off?
Hello, Danny Villalobos, primary care PA out here in Smith Valley, Nevada.
And then Alan.
Sorry about that. I'm Alan Fisk. I'm in Elko technical support.
And Nikki.
I'm Nikki Bain, nurse practitioner at the Battle Mountain Clinic in Battle Mountain.
Great, good morning. Krista.
Hi, Krista Secord, nurse practitioner here in Elko, Nevada.
Thanks. And Dr. Wynn.
Hi, I'm Jacqueline Wynn. I'm faculty for the new family medicine residency program out here in Elko, Nevada.
Good morning.
Nice to see you.
Nice to see you.
Robin Holland. Robin, could you take yourself off mute with the icon in the lower left corner?
Hi, Robin Holland. I'm a nurse practitioner with Women's Health and Pediatrics for Breastfeeding Medicine.
Excellent. Good morning.
Good morning.
I'm sorry, Robin, can you just repeat? I didn't catch where you are.
Here in Reno with
Oh.
Renown.
Oh, great. Nice to have you. Thank you.
Jan Boyer.
Hi, I'm Jan Boyer, a certified diabetes nurse educator at Southern Bands Health Center in Elko, and I'm in my home office right now, and I see we have also tuned in from the clinic.
Yeah, is that Jim, right?
Jim Albitri, yes.
Yeah. Go ahead and introduce yourself, Jim.
Jim Albitri in Elko Clinic, PA.
Great. Nice to see you, Jim.
Thank you.
Great. So we've got a packed agenda. We have two cases to discuss that were both submitted in writing. Thank you so much, Dr. Wynn and Danny, for preparing those cases for discussion. And Veronica is going to talk about gestational diabetes today.
Absolutely. I'll take it from here. So this is going to be the fast and dirty on gestational diabetes. So things we're just going to talk about here, just kind of give you an overview of gestational diabetes, diagnosis and screening, talk about what the targets are, how to manage, and then some recommendations. Carmela is going to jump in on the management because dietary guidelines are probably the biggest way or the best way to manage gestational diabetes. So when we talk about gestational diabetes, the ADA defined it as diabetes diagnosed during pregnancy that is not clearly overt diabetes. So take from that what you will. So when we think about gestational diabetes, it occurs in about 5% of pregnancies, and it is usually increased due to the presence of obesity. It does pose increased risk for the mother and the child. And the things that we see there is the macrosomia, preeclampsia, higher rates of C-sections, neonatal hypoglycemia. And it also leads to an increased risk of type 2 diabetes in the mother and the child in future years. For the mothers, we look at 5 to 15 years down the line of having type 2 diabetes. And the children, because they have a tendency to be obese later in life, they are at a higher risk for type 2 diabetes. So when we think about screening and diagnosing gestational diabetes, There are two ways of doing it. It's the two-step versus the one-step. The two-step approach is the one that is seen most often, and that is testing the women in 24 to 28 weeks. And you do venous glucose measurements after they've had a 50-gram glucose load. And then you test the blood sugars at 1 hour, 2 hours, and 3 hours. So for the two-step test, what you're looking to see is what that blood sugar is after the first hour. And then if they have a blood sugar that is greater than, at the first hour, greater than 180, that is a fail. In the one-step approach, it's a 75-gram load. And at 1 hour, greater than 180. At 2 hours, blood sugars between 153 to 199 is a fail. There is a lot of controversy or conflict around whether to do a one-step or versus a two-step. And the concern is if you do the one-step, there are going to be higher positive rates or more women who are failing that one-step. And in some ways, I kind of sit on the fence because I don't really think that that's a bad thing to find out if people are having some problems with their blood glucose levels. But right now, the recommended approach is for a two-step approach. I do know here in Reno, there are some of the OBs that are just doing the one-step approach, especially for women who have had a fail in the past. And usually, if you're doing the two-step approach, you're looking for them to have two abnormal values in that 3 hour, over that 3 hour time period. So when we think about who we should screen, who should be screened early, because I know in our practice, we often get those women at 30 and 34 weeks gestation, and that's a little late for us to make some changes. So the recommendation is for women who are overweight, so those women with a BMI of 25, or if they're Asian Americans, a BMI of 23. And if they're overweight and have any of the following, so if they've got elevated blood pressure, that A1C is kind of sitting on the fence at 5.7 or higher, low HDLs, high triglycerides, a previous history of gestational diabetes, having a baby large for gestational age or a stillbirth, and certainly folks who are African American, Asian American, Hispanic, Latina, so and down the line. So it is looking at screening folks earlier as opposed to later if they are at increased risk. So once we have screened the women and we find out that they have gestational diabetes, one of the first questions that you get asked is, what should the targets be? So you failed your oral glucose tolerance test, because if you're fasting, if you have fasting blood sugar of 92, that is also considered a fail. So we are asking women to have blood sugars between 90 to 95 in the morning, 1 hour after meals less than 130, 2 hours after meals less than 120, and then an A1C target of less than 6%. And that is less than 6% if we do not cause them to have increased episodes of hypoglycemia. And the reason for the A1C caveat you see there is that says due to increased red blood cell turnover, the A1C is usually lower in pregnancy. However, if you have some women who are reluctant to test their blood sugars as often as they should, sometimes the A1C is kind of a good indicator, especially for those women who come into pregnancy who were discovered to have diabetes at the time that they failed their oral glucose tolerance test. And then you get an A1C and you see that it's, 9%. This is a kind of a good marker for you to kind of follow. So it is usually recommended right now that that A1C be tested once a month. So when we talk about attempting to get these women down to target, the mainstay of our therapy is certainly diet. So diet and exercise together, and then oral agents, I'm going to talk about that a bit because there's some controversy there, and then insulin therapy. But first and foremost, we're going to talk about diet.
Thank you. Okay, so with these ladies, the goal is to, of course, support adequate nutrition to help with both the baby and the mom. Want to make sure that they have appropriate weight gain based upon usually what their pre-pregnancy weight is. You know, normal weight, so normal healthy BMI is 25 to 35 pounds throughout their pregnancy, and then as their BMI increases, we would like to see less weight gain happen with that. And specifically, carbohydrates, knowing that's going to be the thing that drives mostly their blood sugars, is that we want to try to support them with getting in 175 grams of carbohydrates distributed throughout the day, to help with both fetal brain development and then also to prevent any ketosis that could be a problem. Now, I'll tell you, this can be a challenge with women getting to 175. I've experienced lately, especially those that are more difficult with those postprandial blood sugar targets that are pretty strict. I'll talk about that here in a second. And then along with the carbohydrates goal, trying to get to 175 for the day, is adequate protein. So usually I don't recommend anything less than around 70 grams of protein per day. Some of them often need closer to 90 grams of protein per day. It can be helpful for some women to have protein at each meal and snack to kind of help in slowing down the absorption of those carbohydrates. It doesn't always work for every person. Sometimes it can depend upon how much, but generally I'll encourage a protein source every meal and snack. And particularly the morning blood sugars, which can be more difficult to manage, we limit carbohydrates to generally no more than 15 grams at breakfast. That is very difficult for some of these ladies. You know, it may mean half of their slice of bread that they have, or half of an apple that might be a larger size, or, you know, half of a small banana. It's a very small amount of carbohydrates that then really primarily focusing on protein and water at breakfast time. But some can have maybe a little bit more carbohydrates of about 30 grams at that like mid-morning snack time, and then throughout the day 30 to 45 grams. So this is where I spend a lot of time with these ladies talking about carb counting, helping them to understand where their carbohydrates are found, some of those hidden sources, teaching them that a serving of a carbohydrate food is about 15 grams of carbohydrates, and really helping them to understand that sugar is just one type of carbohydrate. That's a common confusion I see people have, is we talk about their blood sugar control, and so they'll look at sugars on food labels and not think about carbohydrates as the thing that will impact their blood sugars as well. People always get surprised about milks and yogurts being a source of carbohydrates. And so that's something that we kind of go into, and making sure that we're helping them to identify of the choices that they're making, which ones are likely contributing to their carbohydrate intake and their blood sugars. And so a lot of times, you know, this is maybe just a helpful reminder, is that for a lot of people, we don't want to encourage that they eliminate carbohydrates, but that we have them in small amounts, and maybe we eat 15 to 30 grams per meal or snack, depending upon how much that they can tolerate. The tricky one that I see people struggle with too is like pasta and rice. A third of a cup of cooked pasta or rice is 15 grams of carbohydrates. So if you think about that for a second, somebody who has a goal of only 30 grams per lunch of carbohydrates, they did not much rice or pasta, right? Not to mention whatever sauce that they may add, or any type of fruit that they may have on the side perhaps, or ketchup, or any of those things, like we've talked about, those hidden sources of carbohydrates. So they have to be really good about reading labels and being honest with themselves about how much they're putting on their plate, to make sure that they don't overconsume carbohydrates. And so lastly, I just wanted to add this in here just to remind us all of this new label that's out. Some manufacturers have already started utilizing this new food label, which is on the right-hand side of this little image here. They've thrown in an extra confusing part. You guys can see that total sugars has underneath it includes added sugars. So that's the amount of sugar that the manufacturer deliberately added to the food that they produced or processed. And that number is included in total carbohydrates. So again, I tell people, you always want to look at first the serving size of what it is that's listed, and then look at the total carbohydrates, and that be their driver, like their main thing that they want to be looking at for carbohydrate counting, and not necessarily worrying so much about sugars unless they wanted to compare products. The main thing is the total carbohydrates. The woman I saw just earlier this week, you know, the portioning out was the biggest thing for her. She was finding that she was likely eating, you know, 2 cups of rice, not a cup of rice like she thought. And then, you know, drinking beverages that have sugar added to them, whether that be juice or soda, which all contributes to where her blood sugars were at. And so carbohydrate counting is very effective of helping these ladies to control postprandial blood sugars. But it does, the educational piece I think is really important in helping them to measure and read labels as being a key part of that.
So then the next part is exercise. And sometimes during the course of pregnancy, women have a tendency to think that exercise is forbidden, but it is not. The exercise recommendations for gestational diabetes are the same across the board. 30 minutes of moderate intensity exercise 5 days a week. They are still trying to get that minimum 150 minutes in per week. And one of the easier suggestions is to have them walk for 10 to 15 minutes after each of their meals to get that time in. The pharmacological management is, so oral agents have been kind of the mainstay, and usually when patients come to me, they've been trialed on these oral agents. I will do glyburide first. Glyburide had been the drug that had been used the most in the past, and the problem with glyburide is that it does show worse outcomes. There is macrosomia and sometimes birth injury for these babies. It is also associated with higher rates of hypoglycemia. So it's kind of fallen out of favor a little bit, but I did put the doses there, starting dose of 2.5 milligrams up to 20 milligrams in divided doses throughout the day. Haven't seen it used as much lately. The other drug that's being used quite a bit is metformin. And the thing with metformin is the benefit is that it has lower rates of hypoglycemia, lower maternal weight gain, but the metformin does cross the placenta and could be associated with preterm birth. The doses are there, and usually the metformin is used a lot of times in the OB practices or for women who are reluctant to inject insulin. Because our mainstay is insulin, it is our preferred therapy. Starting doses you see there, and for a lot of the women it is requiring that they're on long-acting or an intermediate-acting insulin along with a short-acting or rapid-acting. It used to be the mainstay was NPH and regular. We have gone to more of the glargine and levemir along with the analogs in pregnancy so that we can better, as you know, mimic what happens naturally. The advantage of the insulin is that it does not cross the placenta. The disadvantages are the risk of hypoglycemia, excessive weight gain, and I've had some women who are concerned that when they do their injections, especially if they do them in the abdomen, that needle is going to reach their baby and cause some problems. So education surrounding that. And then these days, the cost of insulin therapy. So for these women, I work a lot with the family practice folks. And so for women who are diet controlled, they usually deliver around 39 weeks. Well controlled on meds, they usually get about 39 weeks. The poorly controlled women usually go about 37 to 38 weeks. And then those who are estimated to have some of the bigger babies, which sometimes we can be surprised by, those folks are talked to about C-sections and the likely benefits due to the wide shoulders and things like that. Our overall goal is healthy moms and healthy babies. These are some of my babies. And it is just delightful when it works out well. So recommendations, all women of childbearing age should receive preconception counseling. This is one of those things, as you see on the little stick there, it says, surprise, you're pregnant. That is one of the worst things that I see in practice. So the counseling is necessary. They should be talked to about what the goals of blood sugar control are. And this is I think should be for all women, but if you see the women in practice who have type 2 diabetes, type 1 diabetes, they should be counseled about this. Family planning is certainly suggested, and a appropriate method should be prescribed for women of childbearing age. And as a follow-up for women who have had gestational diabetes, they should be screened between 4 and 12 weeks. It used to be that they were screened between 6 and 12 weeks postpartum, but they have lowered to between 4 and 12 weeks, and they should be screened using an oral glucose tolerance test, and they should be followed every year for the next they should be followed every 1 to 3 years. If that oral glucose tolerance test at 4 to 12 weeks is negative, they should still continue to be screened because the risk of type 2 diabetes is higher in these women. That's it, in a nutshell. Questions?
Great. Thanks, and thanks so much for submitting your cases. It's helpful to us to know what we're going to talk about, and we will get back to you with our feedback.
Thank you so much.
Okay, see you in a couple of weeks. Okay. Hey, Veronica, can you just stick for a second?
Yes.
Okay, thanks. Bye, everybody.
Bye.